Good morning, good afternoon, and good evening, everybody who's joining us today on this webinar. This webinar comes to you from the whole Deformity course, which is run with my co-producer, Professor Hemant Sharma, who unfortunately can't be here this afternoon. We run every year in June, and this year we're hoping still to run a Deformity course, which is both face-to-face for those who can get here and vaccinated, and also virtual for those who can't make it. So I'm very pleased to have two of our senior and regular faculty members from the whole Deformity course joining us this afternoon, Professor Reggie Hamdi from Canada and Professor James Fernandez from Sheffield, both very well-renowned units dealing with deformity correction and with a number of complex and challenging issues. This afternoon we have one of those, which is Osteogenesis Imperfecta, which I think challenges all of us. And because it's not only the challenging and complex surgical techniques that we require, our skills, both implant-wise, osteotomy-wise, soft tissue management-wise, but also in particular, the medical management of these patients per pre-surgery and after surgery, and also the multidisciplinary approach in terms of rehabilitation. I think we probably recognize that obviously biphosphonates since about 1992 have had a significant impact on our management of these cases. But it still remains a very challenging topic, so I'm looking forward very much to hearing from our two speakers this afternoon. Please remember that you can use the question and answer button at the bottom of your screen to raise questions, and we will answer them towards the end of this webinar. And we will have sort of cases, so please participate if you possibly can, ask questions, make use of the availability of our two experts this afternoon, to get an update on how we go ahead with managing osteogenesis imperfecta. So to start off with, I'd very much like to invite Professor Reggie Hamdi to start us off on the topic of osteogenesis imperfecta. Thanks, Reggie. So if you want to share yours.
Yeah, you see everything is okay?
Yes, everything's fine.
Okay. Thank you, Gavin, for the introduction, and thank you, James, for being here. Thank you for inviting both of us. So today talk, it will be Dr. Fernandez. He will continue my talk and be on upper limb, and myself, I will start with general principles and the lower limb. I have nothing to declare. I just want to acknowledge and simply say that everything that I learned in OI was because of these two people, Francois Fassier, who was the chief here, and Dr. Glorieux, who did a lot for the medical treatment of OI. That's the multidisciplinary team, as it was just mentioned. It's now that one person cannot treat OI. It has to be in a multidisciplinary approach. So quickly, OI, it's a group of disorders known as the brittle bone disorder. Most of the cases are due to a mutation in the collagen type 1 biosynthesis. We have skeletal, we have non-skeletal manifestation. We will only deal with the skeletal manifestation. There is no specific test for OI. You can do the molecular testing. However, there are numerous mutations, not only in the type 1 collagen, but in other molecules. The diagnosis remains clinical and radiological. There are many types of OI. The Silence classification initially describes the first 4, and then many other types have been described. What we will deal in this discussion is mostly type 3 OI, who present with the most severe deformities. Why do we treat OI? Well, the goal of the whole treatment is to improve function and improve their quality of life, to make them as independent as possible. They have a normal IQ. Very often it's an above normal IQ. So how can we improve their walking, their ambulation? Two things that we can do. Number one, by making the bone stronger. And how do we make the bone stronger? That's the medical treatment with biphosphonates. Second thing, by making the bone straighter, and that's by surgery, by the rodding. That's what we are going to talk today, both in the lower and in the upper limb. The medical treatment, I'll just mention 2 slides. There is no cure for OI up till now. What we are treating are the symptoms. The biphosphonate treatment that was introduced essentially by Dr. Glorieux many years ago, it reduces the pain, it increases the bone mineral density, specifically cancellous bone of the vertebrae, it decreases vertebral fractures, restores vertebral height, and it improves function. It does not eliminate the fracture. That's something that we have to tell the family. It reduces the incidence of fracture, but certainly it does not decrease, and the children continue to have fracture. The first biphosphonate was an oral one, introduced in 1992. Now we are using a 3rd generation biphosphonate, the zoledronic acid, which is a powerful IV biphosphonate that is given first every 6 months and then once a year. And it started at a very young age in babies, newborn. We started to have them treated with zoledronate. So that's a quick view about the biphosphonate treatment. I will talk later on about how do we fix it or arrange it to coincide with the surgery. These are the questions that we'll go through, and these are the general principles of surgical treatment of OI. Why the rodding? When do we proceed with the rodding? Which implants do we use? How to insert them, antegrade or retrograde? What are the challenges of using implant in OI? And I will finish with revision rodding, which is an extremely important topic. For the surgical treatment of OI, we are going to talk the treatment of fractures, delayed union, non-union, deformity correction in the lower and the upper limb, and if you have time, I'll mention quickly the Coxsackie-Vara treatment. Fractures, a very important thing in OI, it heals normally. There is no delay in the time for fracture healing. However, as we are going to see, fracture in OI do not remodel, and that's the big problem. So if you cannot accept any deformity in OI. The fractures, if they are not treated, they will lead to deformities. Deformities, if they are not treated, they will lead to fracture. And it's a vicious circle that you have to break. You have to break also the circle of immobilization. So you want to mobilize children as quickly as possible. Now we mobilize them within 3 or 4 weeks. And for this, you have to stabilize the fractures. I'll start with a very basic principle. If you have a patient like this who sustains a fracture of the femur in a child with OI, the thing that you should never do is use a plate to fix that fracture. Why you never use a plate in OI? Because if you are using your plate, there is a stress shielding here. Fracture will happen distal or proximal. You are going to use a longer plate and then a longer plate, and you will end up by plating the whole bone. So plating is a big no in OI, as is a single implant. You can use it after you put the rods in to control the rotation, but to use it primarily as the only implant, it's contraindicated. The standard treatment all over the world, it is the use of intramedullary nail. What type of nail, it's another thing. But the intramedullary nails, whether elongating or not, are the standard treatment. Again, why? Because you mobilize them early, you protect the whole bone, and at the same time, if it's a lengthening, then it allows growth. So why rodding? To maintain the bone straight, you minimize deformity, you reduce the fracture rate, you help a quick mobilization so that you counteract the osteopenia. And even when fracture occurs, if there is a nail, the displacement is less severe because there is already an internal fixation. And don't forget, we treat fractures in order to prevent deformities, and we treat deformities in order to prevent the fractures. So which bones to rod? Well, nowadays it's all four long bones are indicated. The indication for femur and tibia are more common than humerus and forearm because these are weight-bearing bone. Deformities can affect the ambulation and walking. However, all four now, if they need, they are fixed. The timing of the rodding is extremely important. In the lower extremity, a child who has bowed bones or repeated fracture, as soon as he pulls up to stand, which is usually between the age of 18 and 24 months, it is an indication for rodding. And usually at that age, most of the time in the femur, we can put a size, a 3.2 millimeters rod. In the tibia, either we can put this size of the rod or other types of nails, as we are going to see. The second indication, if a child sustains more than two fractures in the same bone, it is an indication for rodding. Severe deformities of more than 20 to 30 degrees, either in the coronal, usual, or sagittal plane, whether in the femur or the tibia, this is an indication for rodding. If you are not going to rod them, most likely they will break. Also, children who have persistent pain, this is most likely due to microfractures. So that's also is an indication for rodding. This is just an example, a 2-year-old child, first seen in our unit. She's not standing, she's not yet pulling to stand. She has very severe osteopenia. She never had biphosphonate treatment. Although she is 2 years old, however, there is no indication for rodding now. And what may happen if you try to go and fix it, the bone will be almost like a cheese, and it will be very, very difficult to put any type of implant. So it's much better for a child like this, start biphosphonate treatment, increase the bone density, reassess, and then rodding. Once the child starts to pull to stand, then you do the rodding. What type now of rod? We are going to see any type of rod. It doesn't matter. What we know is that if you straighten the bones and protect them with some form of rod, it helps their function, it helps their ambulation. Well, these are the types of rod. So we have here the regular rods, and these are the non-lengthening rods. K-wires, rush rod, William rods, and elastic rods. Then we have the telescopic rods. They started with the Dubobelli, the Sheffield rods. There are many modifications of the Sheffield. Fasciduval rod, it's the standard now in North America and in some other countries around the world. The problem with this now, it's the huge price of the Fasciduval rod. It's about $3,000 for every rod. This is a modification of the Sheffield. Sliding rods, really it's another name for the elastic rod, one antigrade, one retrograde. Which one to choose? Really, there are many factors that depend on this. It depends on the surgeon experience, on the availability of which implants, on the funding that you have from your company. That's an example of a child who decided to rod all the bones. And as you can see, it's a mixture of K-wires here. You can use rush rods also. You can use elastic nail. The problems with the non-lengthening rods, as you can see here, is that very soon after 1 year or 2 years, you will have to exchange them. And these are, we are going to talk about this. That's a slim nail. It's a non-lengthening rod, but the big advantage of the slim nail is that it has threads proximally that can hold into the epiphysis. And that's a Fasciduval rod. The elastic nail, the standard technique is that you put one retrograde, another one antigrade, and then slide on each other. Still being used in many countries. It's still an excellent implant, especially in the very young, and especially in countries that cannot afford the lengthening nail. Telescoping rod, There is the Sheffield, which is still a rod that is being used in many countries. There is the female, there is a T-shaped here, there is a T-shaped piece here. The classic, the standard one, you introduce the male through the knee. That was a criticism for a very long time. However, there is a publication from Sheffield by Dr. Fernandez, who is going to talk in a few minutes. Still, its very good results were obtained. The criticism that was made was not substantiated in that study, which found minimal problems at the knee and ankle. And of course, the price of the rod, I was just told by Dr. Fernandez, now it's about half the price of the FD. So we'll go the FD, that's the nail that I'm using, that most places in North America are using. And it consists of a female rod and a male rod. You can see here the male rod is attached by threads into the epiphyses distally, and the female is attached by threads proximally. And you introduce the male and the female through one entry, usually, which is proximally here. Therefore, the knee joint is not open. You avoid any problem with the knee joint. However, to have this anti-grade approach, the bone most of the time has to be straight. And now what is being used more and more is a retrograde insertion that I'm going to talk in 1 second. The tibial rod, it's the same. If this is the male rod with the threads attached or screwed distally, and then you have the female rod is inserted above it, and the threads are attached in the proximal physis. Numerous studies have shown that the lengthening rods, whether it's the Fasciduval or the Sheffield, are superior to the non-elongating rods, that they have less complication. However, between the Sheffield rod and the Fasciduval, 5-year survival is about 50 to 60% in all cases. But if you have a choice between lengthening and non-lengthening, choose the lengthening rods. That's a most recent publication that's published in the last month or two. A huge number of patients in 5 large centers. Almost half of them had rodding, and it definitely shows that specifically in the severe type OI type 3, there is an improvement in the quality of life. The next thing now, what size of nail to use. And we should be very, very careful here. Unlike adult patients who use solid intramedullary nail and then you ream 2 size above and you put in a really fit nail so that it's weight bearing, in children and in OI specifically, you never use or you never insert the largest nail. Otherwise, it will be a load bearing and not a load sharing. And there are cases where the bone can disappear simply because there is no stress on the bone. So again, in OI, never implant the largest nail. In the next few things now, I will simply say what's new in the last few years in OI. Well, the first thing that I started to use and the numerous clinics started to use is that as an adjunct to the FD rod, we use a plate. It's a small plate, 2.7 screws that we put at the site of the osteotomy to control the rotation. Because the big disadvantage of the telescoping rod, especially the Fasciduval, is that there is no control on the rotation. So that adds 15, 20 minutes to the surgery. Yes, you have to open the fracture site, but it makes a big difference. So that's the first thing, is use plates as an adjunct. We have 2 nails that have been introduced. There have been no reports published up till now. The slim nail, it's a solid nail. And this solid nail, it's only like a female, and it starts at 2.0 millimeter the diameter. The diameter of the FD, the smallest one, is 3.2. Therefore, in bone with very small diameter, which is one of the challenges in patients with OI, you can use a slim nail. The second nail that has been introduced is the gap nail. Why it's called gap, apart from the name of the person who invented it, it is used in that range, which is 4.8 to 8 millimeter. The smallest adult solid nail is 8.2 that we have. Therefore, between these two, when the facet duval is not available anymore after 6 or 6.2, it's a solid nail and we can use it. And again, with threads here that are screwed in the epiphyses. One thing that I use and other centers use more and more is to do 3D printing of the deformity, specifically proximal femoral deformity, that sometimes it's almost a nightmare to figure it out in what plane to correct. A 3D printing is very, very useful. Percutaneous rodding or percutaneous osteotomy should be done and should be used as much as we can to avoid the wide exposure and the previous shish kebab surgery that was done. So whenever you have to do an osteotomy to realign the limb, try to do a percutaneous one. Positioning, extremely important. So how we position, if you want to do a femur and you want to save time and not use the C-arm too much, we position like this with a small bump under the hip. So that will be the AP and that will be the lateral. And you can change very quickly the position of the leg without changing the position of the C-arm, which saves lots of time. The next thing, very, very important in treating children with OI, and it was mentioned by Gavin, is that the deformities, it's not only bony, but there are soft tissue. If a bone like this or a leg like this has been in this position, not for months, but for years, then you can expect the soft tissues here, how contracted and fibrous they are. Therefore, in the planning, in correction of such a deformity, we have to resect the bone in order to relax the soft tissues here and very importantly in the tibia and to realign the limb. There is no way you can realign safely a leg or a lower limb like this without resecting bone. No way. And it's very, very dangerous. So you can calculate this. Where is the apex of the deformity? Usually it's a multi-apical deformity in several places. There are several coras or apex. You calculate this in your pre-planning, you resect the amount of bone that is necessary, and never be shy of resecting a bone, specifically in the tibia, as there is a very small muscular envelope compared to the femur. And then you put your bone, you realign it. Can we correct the four limbs in the same session? The answer is no, now. It used to be done by Dr. Fassier, by other people in Oman, in other places. It's too risky. And what you end up, if you try to fix the forebone in one session, is that you will end up accepting things that normally you would not have accepted. So the recommendation now is to do one side, like femur tibia, in one day, and then after 1 week or 2 weeks, you do the other side. Another question is antegrade or retrograde technique for insertion of the nail, specifically in the femur and the tibia, and also in the humerus, as Dr. Fernandez will talk now. Personally, and many other people are using the retrograde insertion of the nails. It's much easier. It gives more flexibility to determine where is the entry point of the guide wire and the reamer. If you have a proximal femoral deformity, that's how you position the patient to have a view of the femur, that you can realize the very severe deformity. Try to put the nail from the entry point here. It's very, very difficult. So we calculate where is the apex of the deformity. This is a deformity principles. If the two anatomical axes cross outside the bone, this means that there is a hidden cora is in here. And usually there are more than one apex of the deformity. So where it is, you calculate where is the second or third cora, and then that is the other anatomical axis. So here we are, and that's the part of the bone that has to be resected. So we resect this, and then we do your retrograde nailing, introduce the guide wire, and then you realign the whole bone. The same thing for the tibia. Sometimes the tibia is very, very thin. It's like that's the width of the tibia, like a sheet of paper. That's the whole tibia here, and there is almost no medullary cavity. So it's much safer in a case like this to go retrograde than to go antegrade. I think it's not finished, but I'll finish in 1 minute. The same thing, antegrade or retrograde for the fracture. There is no remodeling after fractures in OI, and that you have to keep it in mind. This is just an example of a fracture of the femur with the sagittal angulation. 3 months later, nothing changed. 6 months later, nothing changed. Okay? So as a general rule, try to reduce anatomically the fracture, and that probably will have to use internal fixation. Antegrade, if you have a simple fracture like this closed, you do a closed reduction, and then you do your standard antegrade nailing. However, a retrograde nailing is indicated if there is an associated deformity. So you go from here, you have to do your second osteotomy, and the principle is that you don't want to leave a segment of the bone here completely free. It will be very difficult to fix. So retrograde is much better, and it is indicated whenever you have a fracture with a deformity. Should I stop now, Gavin, because it's already 20?
I think we still have some more time. I'd rather you carry on. That's great. We don't have any questions at the moment, so please finish off.
I finish off. Okay. The nail in the tibia, so that it does not rub here against the articular cartilage, the best thing is to pre-cut it before you insert the nail. That's the best technique. One word about coxavara. You have to determine, is it a true coxavara or a false coxavara? And how do you do this? By extending the hip so that really you have a true AP of the hip. This is, if you don't extend the hip, it gives a false impression. And this is when you extend the hip, you dangle the foot from here. And that's the coxavara. That's the technique of how you correct. It's very, very well described in many articles that we use in OI and in other elastic bones. Surgery and biphosphonate, it has been published, our results. Our protocol is that we do not administer biphosphonate for the first 4 months post-operatively. As I said, we do tibia and femur on one side, and then a few weeks later, the other side. Very, very aggressive physiotherapy. And that's probably more important than the surgery itself. Okay, 1 minute only. Revision of rodding, what to do and when. Two philosophies. Either we operate automatically on the X-rays once the rods are too short, or when they have completed 50% of telescoping, or you wait until the patient becomes clinically, there is a problem. Initially, I started this, but now I'm very, very aggressive when to do the revision. And I will show you this on 4 slides quickly. These are all the complications that can happen. Okay? I will skip this. I will skip this. I will go to take-home messages. The first take-home messages is that once the bent rods, bowed rods, need to be revised. Don't wait. Don't wait until the patient complains of pain or thing, because other disasters will happen. Once the rod showed bowing, revise it. That's the first take-home message. If you don't revise it, it will pull out of the distal physis, it will break through the distal bone, there will be non-union, there will be many other problems. The second thing, take-home messages, is that try as much as you can to put the male rod distally in the center of the physis. There is a beautiful study that was just published a few months ago showing that if you don't position it in the center of the physis, you invite failure and revision. So the second take home, position the male in the center of the physis as much as possible. The third one is that once the rod stopped elongating and pull from the physis, change it. Don't wait until it bends or it fracture, because if you don't do anything, that's what may happen. There will be a fracture distally, and it's much, much more difficult to treat this than to treat this thing. The next take-home messages, once it's 50% telescoping like this, change the rod. It's very easy to change a straight rod. You need only the entry point. But if it's bent or fractured, you'll have to do another osteotomy. And the last take-home message is that non-unions can be asymptomatic, but then they can also cause many problems. So if you have a non-union and a straight bone, just put a small plate here along the non-union side. And we finish with here. These are all the take-home messages. Very important in OI. Perfect is the enemy of good. Intensive rehabilitation, and do not wait before deciding for revision. Thank you.
Excellent, Reggie. That was a very clear, comprehensive overview on it and management low limb deformities. I always look forward to your talks. And a lot of very important information there, which we can discuss towards the end. We do have one or two questions, which I think we'll probably just take now. You mentioned and you've dealt with the question of 3D printing, which you find very useful in terms of planning, both from the implants and also deformity planning. You also mentioned very clearly that deformity planning is, because it's a multi-apical deformity, as it always is, and therefore it is a challenge and is one of the sort of epitomes of deformity planning. The question here is, in terms of your little plates that you have there, rotation plates, which are an excellent idea, is when do you take the plates out, or do you take the plates out?
Up till now, we didn't have. I started 3 years ago to put the plates out. 3 of them pulled out because the bone was so weak. They pulled out. Most of them are unicortical also, so it's not a very good grip. But revising plates alone, apart from the 3 that pulled out, I never had to do one up till now.
And another question, how do you manage the very low supracondylar fractures in the femur in osteogenesis imperfecta?
The supracondylar in the femur, I had one example here. It will be the same thing. If I can put a nail, it will be like a solid nail in the adults. The 2 that happened, it has to go through the physis, distally, straight the bone, and the combination of K-wires and the plate. There is no magic solution there. It's probably one of the most difficult situations. But the 2 that I have done is crossing the physis, obviously, distally. We don't have a choice for this, and then fixation with K-wires.
Excellent. I agree with that. I think combination fixation in these very low fractures is the key. Whatever combination you choose, whatever combination you are happy with dealing with in your practice. Excellent. Okay, so there's another question, but this relates largely to the upper limb. So I think we'll perhaps hold that question to the end and ask James at the end of his talk. Great, James. So if you could go ahead with your talk, that'd be lovely.
You all can hear me? Yeah.
Yep.
Yeah. So thanks, Gavin and Hemant, for inviting me, and it's great to be on faculty with Reggie, a good friend who visits Hull most of the time. So I'm doing the second part of the talk, and though the femora and the tibia are larger than the humeral and forearm bones, life becomes a bit more difficult when you have to touch the upper limb. Sorry. So my talk will have goals of treatment, a bit of orthopedic aspects. There might be a little bit of overlap, our Sheffield experience, some challenges when we do upper limb, a bit of our audit of our upper limb humeral series, and some conclusions. So overall, the goals of treatment remain the same. We want to maximize their function, reduce their disability, get them to integrate socially, and give these kids independence. And not every time we can give them best mobility, especially most of our tertiary centers, like Reggie and like Professor Hamdi and myself, we do predominantly type 3s. And therefore, there's significant problems of getting them up or standing and make them mobile. But overall, maintain overall health. And like everyone has mentioned before, it's a team approach. So the primary 4 things, just to repeat: prevent and reduce fractures, correct deformities, improve mobility status, and therefore indirectly the function. But why treat the upper limb? So when I first came to train in Sheffield under Mike Bell, my previous teacher and my colleague who was retired now, we didn't have enough time to look at the upper limb. We had enough of work that we predominantly looked at lower limbs. But now, since the lower limbs are being done quite well, their mobility has increased. These kids have to require the use of aids. And in severe osteogenesis, where they possibly may not be able to stand or walk, they need to ambulate as well. So with the wheelchair. So therefore, the upper limbs have become a bit more important, and we started to do them even more than previous times. And these I call the difficult segments. And if you look at this one, you have a humeral non-union there, partly because there's a contracture at the elbow and deformities of the forearm. And these are also drivers for non-union. And since the arrival of bisphosphonates, many of these children where they have transverse classical fractures, they're predominantly because of conversion of brittle bone to dense bone. And therefore they get a bit like osteopetrotic fractures. If you look at this kid, age 10 years, went on to have a non-union. We didn't have much kit those days. We used like an elastic nail. It did not heal. And then went on to have a little modification by shortening, grafting, and some sort of tension band wires. This is the example of the Sheffield rod, just to show you. We don't use that now in the humerus. As you can see, the T-piece is a bit large at the top end, but at the bottom, it's very difficult. It comes in the way in the olecranon fossa. And you can see that we have attempted in the past even going to the olecranon fossa. Of course, with growth, they migrate. And you can see the forearm here treated with two wires, K wires. Interestingly, when you actually see some of the severe ones, the distal mid ulna is usually so thin, you can't even drill. And when you start drilling it, even with a 2 millimeter drill, it just splinters, partly because of bisphosphonate. But many of these kids have significantly severe deformities, as shown in these 3 different examples. And look at this child when little, actually the elbow joint is here. And it looks like there's another elbow joint here, but it's actually almost a 90-degree bend. So the elbow joint is where I've marked with the marking pen. So just to show, to repeat what Professor Hamdi had mentioned about pre-operative planning, it's quite important and paramount. And of course, the whole concept of deformity correction can be applied everywhere, even in these severe dysplasia patients. Technique. So though originally some of our humeri we started doing from antegrade to the shoulder, we thought we'll start using from the distal end. And this is just to show you the starting wire to ream through the just above the olecranon fossa. And because many of our deformities were quite distal. This is actually a TST rod, which is produced in Turkey. It's cheaper than FD by almost half. And we have trialed it. And of course, there's not a big difference, like Prof. Hamdi says, between all these elongating rods, apart from the cost, I would say. But sometimes at the site of drill entry, you may land up with fractures. This is one of these, but we of course treated it with just with plaster on top of it. Even to put wires, it's very difficult to hold in that region. A kid who had the forearm correction, just to show you, minimalistic approaches rather than open the whole radius or the ulna or the old cheek kebab type of technique. You can see here an example of where the humerus was done previously, but you'll be wondering why this nail is going outside the middle of the ulnar segment. It's partly because we can't go through it. So we quite often land up doing what I call endo-exo-endo technique. And we just need 2 small incisions to do that, and does not produce great problem with in terms of mobility. There will be some restriction of supination and pronation, but these are all severe deformities, and the quality of the bone is also poor, so is the canal size and the width of the bone. This is a series of example of one child who was actually left in respite care thinking he was going to die, but fortunately he went on to survive. He's a great lad, and if you see his forearms here and severely bent, and you can see we have done the same technique for him. And there it is, he's got his scars where his osteotomies were done for the humerus, and you can look at his function, even playing on his iPhone. And the problem when it comes to the forearm bones, unfortunately, we don't have a kind of narrow enough nail to get purchased with threads. Possibly even the narrowest slim nail may be difficult, and the wire had backed out, and he went on to have this fracture. It was not painful, and just 2 or 3 weeks ago I had to revise. But can you see how we have done the same? We cannot actually translate most of the segments or go through them, but his forearm looks straight. So here in forearms, sometimes I ignore the bone, I look at the forearm to make it look like a forearm. Just another few examples here, a combination of where we have used only an ulnar wire here, as you can see, and used a TST for the humerus. This is a recent one, a chap from London who used to play, he's not a type 3. He had multiple fractures with significant malunion and restriction of supination. And we have used, as the most important thing is you need an internal rod, which Professor Hamdi has very clearly mentioned. But it is his forearm. He was a type 1, I think. And we used the EVOS plate to control rotation and correction. And that's it. At 3 months, he's got his sort of clinical pictures in addition. Abstract. And there was a paper by Amako saying that self-care scores of PEDI were significantly low with severe deformities of the upper limb in OI. Similarly, the mobility scores as well. So we thought we look at whether by doing surgery in the humeri, whether there's improvement in the range of motion of the shoulder, elbow, change in status, looked at radiological union at the osteotomy site, and also complication rate. This is a little busy slide, but we looked at quite a few analyses. If you see some are severe deformities, we classified them into degrees. We also looked at the levels, lower third, middle third, upper third, or combined. Then we looked at even number of osteotomies, whether single or double components and types of rods. There were 26 procedures in 14 patients with mean age at 8.5 years. 3 of them were revision, 7 equal boys and girls. And if you look at the preoperative angulations, both AP, lateral, and oblique, they are quite severe. And actually, the 12 of them are the severe type. And again, 12 were lower third. So one of the reasons why we decided to go retrograde is because most of the deformities in the distal third, trying to go antegrade, we may not have a great purchase in the distal segment. And these were the apices 17, a single apex, 5 were bifocal. Quite often we landed up using just a female component. There were equal TST and FD rods. We had moved on from Sheffield rods, so there were only 2 in the recent past. So out of the 12 of the 14 children, what we had reports from, 9 of them had improved transfers and ability to propel the wheelchair. And it so happened that these children are all on Facebook, and they tell each other, and very soon more of these children were asking for surgery on the upper limbs. Very interesting what social media can do. The mean follow-up was 12.4, and most of them united by 6.5 to 7 weeks. And if you look at this slide, I'm just going to highlight in red the range of motion at the shoulder and the elbow, which had significant improvement in their range, which was evaluated at 6 months. But if you look at the complication rate, almost 34.6%, and mainly if you see the ones, and these you can see are 5 of them had a fracture at the distal end, which was very difficult to control. Putting wires is not a great idea at this area because they don't have any purchase, and we were not using any additional plates like the EVOS plates at that time. We realized that the variables affecting complication were severity of the deformity, the level of the deformity, and number of osteotomies. There was no influence from the implant type or the implant crossing the physis of single or double components. And this is just an example. So not all OIs come with one diagnosis. This one has also got GMFCS5 cerebral palsy, and she was fracturing as well. She went on to have the forearm later on, and she did reasonably well. This is another type 3 OI boy who was struggling to write and use the wheelchair. But here, if you see, we have put a single Sheffield rod. So in the discussion, there are quite a few papers which have been published where they have shown improved self-care and mobility score after upper limb surgery. But if you look at fracture rates, especially if you look at the one from Grossman, 12 out of 35 required revision at 35 months. But for Franzoni, who in their paper in 2017, the fracture rates were reduced because now you got an internal splint. But if you look at the Karbowski's paper, where they use a Bailey-Duber rod, 8 of the 14 needed reoperation due to migration or infection. So humeral rodding does improve functions and mobility with no compromise of unit, but there are higher intraoperative complications inherent to severe OI as expected. And I think combined deformities, upper third, and deformities more than 90 degrees, as well as more than 2 osteotomies. I myself have had a steep learning curve for these challenging segments. But the benefits are such that we are having more and more requests for forearm correction. There's definite improvement in wheelchair use, especially our occupational therapists tell us anecdotally. We are going to assess this as well in the future. And I suppose we need to prospectively evaluate. And also better aesthetics. Parents also like the looks of the arms as well as the children. The type 5s is a completely different ballgame because many of these develop heterotopic ossification when you do surgery, and their classic is where their radial heads dislocate. I tried not to operate on any one of them, and they're young. Many of them are waiting, and if they're giving trouble at skeletal maturity, probably the option may be under cover of indomethacin to excise the radial head. Just though this is not OI, I thought I'll just add another condition, that is McEwen-Albright, where it also behaves the same way, where you can even use adult rods and even similar principles of using elastic nails, which we sink inside the bone in the forearm. To conclude, the upper limb definitely has a bigger steep learning curve. I think maybe we need some more improvements in implants. The costs are quite prohibitive in terms of when you try to do multi-segment surgery. And I think we used to ignore the upper limbs, but now we are giving more and more attention. And the involvement of the whole team is so beneficial, especially when the metabolic physicians, their OTs and physiotherapists, as well as getting involvement from the Brittle Bone Society or parent support groups. Thank you, and I would like to thank Sanjay Chilbole, who did the audit on our humeral analysis. Thank you.
Excellent, James. That was again very good, and just shows what a challenging aspect osteogenesis imperfecta as a condition is. When you think the lower limb is challenging, when you start looking at the upper limb, it's even more challenging. And I think what you stressed there was that the decision making as to what to do, when to do it, with very specific goals that are very specifically patient orientated, again highlights the multidisciplinary approach that you have. Before we go into any further discussion, perhaps one or two questions we've had here. So I think the first one, James, is any tips for the distal third humeral fractures, a bit like the supracondylar fracture of the femur? Distal third humeral fractures, do you have backup rods and plates? Again, I think the same issue.
Yeah, I think we never used to see that many distal third fractures. I think with bisphosphonates who have not been stabilized, they are the ones who develop a fracture. But it is not in the supracondylar region. It's slightly higher, and they're very transverse. I suppose it's the same choice of putting a rod from inside or nail, but I think I would now add maybe a small EVOS plate, which is a 2.7 millimeter plate, and it's got locking capabilities. Of course, some of the screws will be unicortical, and some possibly you can do miss the nail kind of technique.
Good. So I think the biphosphonate question keeps coming up, and while we have improved the bone quality to some degree, the biphosphonates has given us other problems, as we know in adults, and certainly these biphosphonate type fractures and the management of them because of the lack of bone modeling that you get. On the question of biphosphonates to both you and Hamdi, what, again, just to go over your time intervals in terms of giving pre-operative biphosphonates, and also then when you recommend post-operative biphosphonates.
Okay, so if they have fractures, whether they have been given biphosphonates just before, a week before, we ignore, we still go and stabilize them. When it is for deformities, usually the traditional rule was that we skip one cycle of pamidronate, and then 6 weeks after the surgery, as soon as we see some healing, we usually allow the metabolic bone team to give bisphosphonates. I think the biggest difference has made is because we have moved on from open big surgical incisions to minimalistic incisions, and we no more, I don't use a saw blade to cut any bone. It is all done with multiple drill holes with cooling, and then sometimes, quite often, you just need a bone nibbler to break the bone or bite in small bits. So I think our soft tissue handling has so improved that our healing is much, much better than what we used to have before. And I don't know whether Professor Hamdi will agree with me on that.
Reggie, unmute yourself, yeah.
Yes, it's almost, we are following almost the same protocol. Before the surgery or osteotomy, it doesn't really matter. Like we have very often who have received the dose of biphosphonate and then either fracture or they are here. So pre-op, it doesn't matter. Post-op, as I mentioned, as a standard, it's 4 months without biphosphonate. However, if they are from here around the Montreal, we follow them, and I agree with James, as soon as they show signs of healing, we can give the same dose. We continue with them longer. There was a question of do you give a biphosphonate holiday or not? I would leave it that to the medical team. We continue, specifically if they have pain, we start again with the biphosphonate. But does it really have an effect on the fracture incidence? It's still very, very doubtful and controversial. For sure, it improves the quality of life, it improves the ambulation, it improves vertebrae, but the incidence is quite thing. However, in children, we haven't seen the problems that in adults they have. Like we don't have atypical fracture, we don't have the typical subtroch fracture in children. That we haven't seen them.
Excellent. I think also, James, you mentioned it, but to stress this, that we're doing more percutaneous osteotomies. We're respecting the soft tissue, therefore the biology. Biology is very important, but also the technique of doing osteotomies, because in the presence of biphosphonates, we have more brittle bone. So although we say, okay, let's do drill hole osteotomies, I think you will be careful using drill hole and osteotomes. You know, drill hole and nibblers, as you mentioned, there are a great way of freshening the bone ends and of not getting a shatterotomy as such, you know, using the osteotomes because the bone is so brittle. You agree with that?
That's absolutely right. Yeah, osteotomes is a no-no. It's usually drill holes and just a nibbler. So it's quite often that's the case. But we cool the drill bit all the time while we drill.
Yeah, the other thing that we always tell them is that biphosphonate increases the bone mineral density. However, bone mineral density has nothing to do with the strength of the bone. The bones remains brittle, and we see it very often where our medical team say, look, he's on biphosphonate, the BMD is good, go ahead and operate. And sometimes we go in and the bone is like, it's splinters everywhere.
Excellent. And I think also, as you both have mentioned, is what is very key, not only is the managing the biology of these patients in terms of the surgical side of things, but the biomechanics. Really, you can choose whatever implant you like, but optimizing the mechanical axes, the biomechanics, the stresses across the joints and through the bone is absolutely key in these patients. And you can't really accept deformity. You must really go for, maximum, deformity correction, even more so than you would in other patients in reconstruction. So we also have Professor Hemant Sharma has joined us very kindly. Fresh from surgery, dealing with pus as usual. Dealing with pus. Any comments, Hemant?
No, that's, it's a very difficult situation, and we have two world experts, so there's very little I can comment in. Gavin, you do all these kind of things. All I can say is that the planning is quite important, and if you can plan it, and then you always have a better chance of getting decent results.
Excellent.